Kirby. I'm Associate Dean of Research, and I'd like to welcome you to the 2018 Schofield Memorial Lecture. I'd like to welcome alumni and faculty, staff, students, and especially Lisa Schofield, who's Frank Schofield's granddaughter, is here for the lecture today. Welcome. So I'll give a little background for those of you who don't know about Frank Schofield and this lecture. I'll give you some background on that and then introduce our speaker today. So the Schofield Memorial Lecture is dedicated to Frank Schofield. He was an influential pioneer of veterinary medicine in Canada. He immigrated from England as a teenager and entered OVC in 1907. Soon after he graduated, he traveled to Korea as a Canadian missionary to teach bacteriology. He was heavily involved with the defense of the Korean people against the Japanese occupation there, so he had to leave Korea. He returned back to OVC in 1921, where he worked for 33 years. On retirement, he returned to Korea to work at the College of Veterinary Medicine in Seoul. In recognition of his distinguished services to Korea and Korea's independence, Dr. Schofield became the only foreigner to be buried at the National Patriot Cemetery. While Schofield had many significant contributions to veterinary research in the first half of the 20th century, probably the most important was his discovery of the antithrombin substance in spoiled clover. Through his systematic investigation of hemorrhagic disease in cattle in 1922, Schofield made several astute observations that traced the disease to cattle that were fed sweet clover that had been spoiled by mold. His observation in clinical trials that only calves fed the spoiled clover eventually hemorrhage revealed the problem with blood clotting factors. The compound dicumarol was eventually identified as a causative agent from the moldy clover and developed by the University of Wisconsin into the drug called warfarin. And this was through funding from the Wisconsin Alumni Research Fund, and hence the name warfarin. The Schofield Memorial Lecture celebrates Frank Schofield's life, his research, and his role as a motivational icon and a proponent of meticulous scientific inquiry, who undoubtedly inspired many of the subsequent research achievements here at the college. Dr. Schofield provides us with the incentive to achieve the highest standards of effort, intellect, and ethics, to practice evidence-based medicine, and to strive towards translation of our scientific discoveries into effective advances in both animal and human health. So we're very pleased today to have Dr. Wayne McIlwraith, traveled from Colorado State University. I've been apologizing for the cold and snowy weather here, but apparently it was cold and snowy at Fort Collins, so you're well used to that. Dr. McIlwraith obtained his veterinary degree from Massey University in New Zealand, was in practice in New Zealand and UK, followed by an internship here for a year, and subsequent surgical residency at Purdue University. He also obtained an MS and PhD degree from Purdue University. Since 1979, he's been a faculty member at Colorado State University. He's currently University Distinguished Professor, holds the Barbara Cox Anthony University Endowed Chair in Orthopedics, and is the founding director of the Orthopedic Research Center. He also has a referral equine practice in orthopedic surgery in Southern California, and is a consultant and surgeon for clients elsewhere in the US, in Ireland, England, France, and New Zealand. His research interests focus on equine orthopedic surgery and translational joint research, including novel treatments for osteoarthritis and articular cartilage repair, mesenchymal stem cell therapies, and early diagnosis of osteoarthritis and pre-fracture disease using imaging and fluid biomarkers. He's authored 6 textbooks, 450 scientific publications and textbook chapters, and many presentations. He has honors that include doctoral degrees from the University of Vienna, Purdue University, Massey University, the University of Turin, and the University of London. He also has the Founders Award for Lifetime Achievement from the American College of Veterinary Surgeons. Dr. McIlwraith is a visionary who is a big picture thinker. As mentioned, he's responsible for the inception of not only the Orthopedic Research Center, which is known worldwide for research in the pathogenesis, diagnosis, treatment, and prevention of musculoskeletal disease and injury, both of animals and humans, but more recently for the C. Wayne McIlwraith Translational Medicine Institute. The TMI draws on the specialties and expertise at CSU, research in orthopedics, biomedical engineering, immunology, infectious disease, and surgical advances. And this helps expedite the development and commercialization of discoveries in translational medicine to new therapies. I understand that the correction of the construction of the building is virtually complete, and they'll be moving into the building in December. So we're very fortunate to have Dr. McIlwraith return to Guelph to give the Schofield lecture. In my letter or email of invitation, he responded saying that his career in North America started here at Guelph with an internship in large animal surgery, and it was a pivotal year for him and his career. Please join me in welcoming Dr. McIlwraith.
Thank you, Dr. Kirby. He didn't need to tell you about this name being on a building. It's still a little embarrassing, but I'll talk to you about that at the end. It certainly wasn't my doing. Thank you for the honor of presenting the Schofield Memorial Lecture. It's great to be back at Guelph. So the title is Joint Injury and Arthritis. My secretary still struggles sometimes with my accent and put in. I noticed when I was getting ready for this lecture before I came here that it was in instead of and. Obviously they're two different but strongly related situations. Helping horses and humans using translation of clinical and research science. So these are my disclosures. So early history, which Gordon has already mentioned. I did my vet degree in Massey. I was in mixed practice for a bit over 2 years. I then went on a climbing expedition. I knew I was leading a climbing expedition in the Andes. This was my other passion at the time. Then had some locums in the UK, followed by a season in the European Alps. Anybody who's a serious alpine climber has to go and try and get up certain north faces in Europe. So I put this picture in later. These are pictures in New Zealand. It was a big part of my life when I was a vet student. But as the saying goes, at some time you have to grow up and focus on a career. So, and this is where it started. You know, I had an internship in large animal surgery at the OVC. It's kind of an interesting story because in New Zealand, when I graduated, they didn't have any internships and residencies. The only form of graduate education was going straight into a research track and doing a PhD. That was the last thing I wanted to do, but I ran into a vet student who was a veterinarian who was 3 years ahead of me, graduating from Massey at a party in London when I was in England during that winter. And he asked me what I wanted to do, and he said, and I told him I'd like to specialize in equine surgery, but I didn't want to do a PhD. Well, I ended up doing one of those, but that was a different time, as I'll explain shortly. So Doctors Don Horney, Frank Milne, and Rhys Owen were the surgeons. Rhys was a particularly enthusiastic person who, when I review it, he's the first clinician scientist that I really worked with. And then my intern mate was Dr. James Moore, who's gone on to a very distinguished career. But the important part of that whole year, which was really quite phenomenal for me, was that I knew what I wanted to do for the rest of my career. So I got a residency at Purdue. I thought Purdue was, I'd never been to the US, and when I got, the first thing that happened after it was known that I'd accepted a residency there was Bob Curtis, food animal clinician here, came to me and said, "McIlwraith, I hear you're going to Purdue." And I said, "Yeah, isn't that good?" He says, "You're too wild for them." And on review, the only Americans I'd met were either mountain climbers or Americans down in South America for the cheap cocaine. So I did have a little bit of a biased view of the typical American, and believe me, it's not the same as the residents of Indiana. But I got on well and I had a great time. Anyway, two very important people. Jack Fessler was the supervisor. He was the one that called Don Horney looking for a resident, and Don Horney told me I should go there and told Jack Fessler he should take me. So that's how it ended. It's kind of like a blind date. Two pivotal events at Purdue. The first was an introduction to synovitis. They gave me this model Jack Fessler had this project in synovitis, and Dave Van Sickle, who was already an expert in arthritis in the dog, he'd done a lot of work in military dogs, was on my committee, and then later on he invited me to continue the project into a PhD. But back to the two pivotal events. While I was there, I was introduced to synovitis. There was no literature on the horse, very little. There was a comparative pathology study written by a veterinary pathologist and a human pathologist on joints and osteoarthritis changes. And the human literature sort of rejected synovitis as a primary pathogenetic pathway for OA. It was just an idiopathic disease that had synovitis as a secondary result of debris into the joint. So things have changed there, and I'll come back to that. But it introduced me to arthroscopy, because I thought, well, if I've got a model of synovitis, why don't I see if I can look in the joint? And I read about the arthroscope, and I'll come back to that in a minute. So the master's research project that I had in my residency was pivotal. It gave me the idea of monitoring joint disease with the arthroscope. And I still can't remember, it's very frustrating, I can't remember now where I read about the arthroscope, but it led to my calling Lanny Johnson, Dr. Lanny Johnson, who was one of the pioneers of arthroscopic surgery, and asked him if I could come to his course that I'd seen advertised somewhere. And he said, sure. He said, I won't even charge you registration. I told him I was a veterinary surgery resident. So 100 MDs and I learned how to do a diagnostic arthroscopy of the human knee. And they were pretty scary times when you look at it, because at that stage, if you had medial knee pain, they often just did an arthrotomy and took your meniscus out. And quite often that meniscus was normal. Then you had an unstable knee, so it went on. But it also, the research project precipitated a long affair with joint disease and raised many questions on cause and identification of targets for therapy, diagnosis, and validation of treatment, which has essentially been the rest of my career. What we did is that we studied synovitis, and we just induced it with an irritant material. And at that time, the dogma was you'd have to have instability, you had to have direct trauma. And so this is a Van Giesen stain and showing the glycosaminoglycan as blue. This is normal. And this is after a period of inflammation. We start losing the component proteoglycans, which probably nearly everybody here knows gives you the compressive strength of the cartilage, and you're starting to get morphologic breakdown at the surface. Now, the human literature is now replete with attention to synovitis, in addition to primary trauma to the articular cartilage and bone. But that's how we got into looking at the synovitis literature, and I'll come back to that as it's relevant to human OA in a minute. I've already told you how I ended up at Michigan State with Dr. Johnson in his course, and of course came back and started doing diagnostic arthroscopy for many years, quite a number of years. We had to look through the scope. It made it difficult to teach it to people. And then later on, we evolved into doing triangulation. The principle is getting the instrument in the other side and being able to focus on the lesion and treat the problem arthroscopically. And of course, everybody knows that arthroscopic surgery revolutionized equine orthopedics like it did with human orthopedics. It started with diagnosis. This is the first paper we wrote on it. And at the end of the PhD, I was lucky enough to get hired by Colorado State University. Dr. Simon Turner was the initial advocate of my coming to CSU. Dr. Adams was planning on retirement. Unfortunately for Dr. Adams, he passed away the day after I died of a heart attack, the day after I passed the surgery boards, the boards for board certification. I interviewed a month later and was lucky enough to get the job. The department head was Dr. Jim Voss, who featured in a number of ways in my career after that. But back to arthroscopy, obviously we continued doing it at CSU. I wasn't the only one doing arthroscopy by then, but with residents and fellow faculty, we developed quite a lot of the techniques. But I also worked outside CSU because I was the only person, at least in the West, doing arthroscopic surgery. I got invited to go to various places and to the East Coast as well. Probably the other significant part of my life was that this young veterinarian, Dr. Nancy Goodman, asked me to come down and do arthroscopic surgery and show her boss, Dr. Bart Baker, about what arthroscopy did. This is a picture in a 1984 Quarter Week magazine with Nancy behind me assisting, and as you can see, we're looking through the scope. This was one of our first cases that really put arthroscopy on the map. This horse, First Down Dash, had chip fragments in all 4 carpal joints as well as both front fetlock joints. We did at the end of his 2-year-old year, and that's him coming back and winning the Champion of Champions, the biggest race. So it allowed us to take even multiple joints and operate them. As an aside, I ended up marrying Dr. Goodman. That's another story. But and so then it led to the publications, textbooks, and of course it's a standard technique now. But it was started by that research project and thinking that that might lead us into looking at synovitis. Now, there were challenges with arthroscopy. There were the technical challenges of getting your visual field, your instrument, and your 3D perception together to do the surgery. And so it didn't suit everybody, but, you know, plenty of, it's standard technique now. And the same challenges in human. These were probably the bigger challenges were acceptance and conversion, because some people who didn't like the idea apparently had a love affair with arthrotomy. These were a couple of the comments that I always thought were the most amusing. I heard this quite a few times. This was unique. This was specific to one veterinarian who did a lot of surgery in Kentucky, a well-known veterinarian. He called the arthroscope the instrument of the devil for about 5 years before Dr. Bramlage in Kentucky converted him. This is sort of a horse that helped. You know, you've got to have it. It was easy getting acceptance by the majority of the veterinary profession. It wasn't so easy from the industry because the naysayers were talking to the trainers, were talking to the owners. This was a chip fragment in a horse that I went and operated in Miami in 1984. Chip fragment off the proximal intermediate carpal bone that the surgeons in the audience know is a sure thing when it comes to success. And anyway, this horse 5 months later won the Kentucky Derby by 6 lengths, led wire to wire. Obviously, I didn't make him any faster, but at least we allowed him to pursue his potential. And so that really, arthroscopic, all the arguments were kind of over after that. And then, of course, more advanced arthroscopic techniques followed. And we do lots of things. If we can get the articular surface in this condylar fracture back together as we have here, put it together, these horses can come back and race successfully. Similarly with slab fractures, not in every one. In this particular case, it's a collapsing slab fracture, but you can save the horse's life with internal fixation, which we still do arthroscopically. And here's the big however, which really is the rest of the talk. Limitations were recognized. You know, acute articular cartilage loss in association with traumatic injury, and of course chronic disease, which would lead to osteoarthritis. And this led to development and the quest for better regenerative therapies. And these therapies are an important focus of our research at CSU, at the Orthopedic Research Center, but other centers, certainly here, and a number of other places in the US and also in the rest of the world. The questions: how do we preserve the normal joint? How can we reconstitute normal joint tissue, particularly articular cartilage? Nobody has figured out how to perfectly regenerate articular cartilage. And healing of tendon and ligamentous injury is also a focus of this program. So a little bit about the development of the ORC and how we got there as it's relevant to us working through these problems. And as I've said before, we weren't the only ones doing it. But I was a clinician in the veterinary teaching hospital for 15 years, but I was still doing research. I'd done a PhD at Purdue, and I really wanted to do research. I had a number of small grants and residents and grad students, a number of PhD students, but nothing like I really wanted to grow the program into. We had too many questions we wanted to answer, and you'd get those questions thrown in your face every day when you're doing arthroscopic surgery. As Gordon mentioned, because of my relationship with Dr. Goodman, the first 16 years we were married, I did surgery there every other weekend. She worked in California 8 months a year. But you'd always come home having new problems that you wanted to develop in the lab. Dr. Jim Voss was dean at this stage, and he gave me an offer I couldn't refuse. He said, I want you to take over director of equine sciences, which included an undergraduate program and the equine reproduction lab. But I'll give you, for that, I know that's not what you really want to do, but I'll give you a tenure track position in orthopedic research, a secretary and a technician. And I challenge you to build the best orthopedic program anywhere, research program anywhere. So obviously I'm not the one to judge whether we've achieved that, but we certainly have had a decent go of it. So he helped me to renovate lab space in an old dairy building. The dairy building was over here. This is our Gail Holmes Orthopedic Research Center here, where we've done all the live animal research, and then we have an MRI center between this building and that building. This is a twice renovated dairy husbandry building that's now all basic research labs, and then we have a gate lab out the back. And with that position, I actually hired a Canadian, Dr. Clark Billinghurst, who had done his PhD with Robin Poole in biomarkers, because that was a focus of our research. And I stayed over at Equine Sciences on what's called the Foothills campus for 7 years. By that time, we'd built the program up. I wanted to come back and focus on the Orthopedic Research Center, and we needed to raise money for buildings. And so this was when I went in '94, when I got a position for Dr. Billinghurst, we renovated one room in this building. It certainly didn't look like it does now. And then we got the funding, private funding, to build that center. As far as building a program, you need facilities at a certain level, but the real critical thing are people. And so this was another significant moment in our building the program, in that Dr. Dave Frisbee in the middle there and Dr. Chris Kowchak on the right, they'd done their residencies with us, they'd done PhDs with me, and I wanted to keep them. And at that time, the traditional position was 50% clinics, which often could translate into 80% clinics. We said, let's change the model so that if I can get you funded, you stay here as special appointments with a primary focus in research, but certainly us finding ways of, they both wanted to be surgeons, of doing your clinical options. And so a client of mine, and still a client, Maria Niarchos, who's the daughter of Stavros Niarchos, she funded me, and she's they're major horse owners internationally. She gave me 4 years' salary and benefits for Chris and Dave as assistant professors. And so that was really a critical move, where I sort of went from an N of 1 to an N of 3, and then later on with additional technicians. We already had techs, I wasn't counting the techs at that stage. We've built up the program somewhat with additional endowed chairs, and obviously Dave and Chris are in permanent positions and have just recently taken over leadership of both our Orthopedic Research Center as well as the clinical equine programs at CSU. So what about our Orthopedic Research Center? What are our focuses? Well, articular cartilage healing, early diagnosis of musculoskeletal disease. These are broad, improved understanding of the risk factors for traumatic musculoskeletal injury. As you know, a catastrophic injury, particularly on national television, is a terrible event. It's still a huge welfare problem for us. We've done quite a lot of work with biomarkers for that, and that's still continuing. Continued development of novel therapies, that'll be most of the rest of the discussion, and investigation of rehabilitation protocols, which is relatively new and we'll also talk about. And of course, we were initially addressing equine problems with these focuses, but later translated them into research. So post-traumatic joint disease is a common clinical problem in the horse. Surveys estimate that up to 60% of lameness is related to OA. These horses are athletes. They do great things, but also the trauma. You know, with thoroughbred race horses, it's usually cyclic trauma. Similarly with racing quarter horses. On the other hand, with cutters and reiners, it's incredible pressure on their femorotibial articulations, their stifles, as well as their hocks. But this is sort of a perfect model of trauma comparable to the human knee, and we've utilized that comparison quite a bit. As far as people goes, there's over 40 million people in the US affected. Some surveys have even a higher level. By 2030, there'll be 67 million people estimated. Soldiers and war veterans have a high rate of PTOA due to combat injuries. And one of the good news, bad news is OA doesn't kill you in general, but it puts your life into a miserable situation a lot of the time. And actually recently there's just a paper that I just noticed last week where they're showing evidence for people with osteoarthritis being more prone to heart attack and being more prone to other accidental deaths. So it's a big problem. So we've got this situation where it occurs in both horses and humans. And that is what a lot of our more recent focus has been on, the translational aspects of that. It involves a complex interaction of biologic and pathologic processes highlighted by eventual degradation of articular cartilage. And of course, we see a spectrum of disease. We may have mild osteophytosis clinically on the radiograph of the horse, but then when we get in there, we find this damage to the articular cartilage. Sometimes we find fragmentation. And so we've got two problems. The first one is, of course, early diagnosis is critical, and then effective treatments that you can correspondingly use after you've got that early diagnosis. And then later on, the surgery comes in when you've got some more obvious and severe injury. Now, we haven't got time to dwell on the individual pathways, but this is sort of I just try to make some comparisons between the horse and humans. This is a diagram that I first made up in 2005. Making the point that we have cyclic trauma that can lead to change in the articular cartilage directly, or it can make it indirectly. A lot of the disease processes sort of set our articular cartilage up for succumbing to trauma that it wouldn't normally, be hurt by. And then, of course, we have the direct injuries on abnormal cartilage, that all lead to morphologic breakdown of articular cartilage, or the progressive deterioration of articular cartilage. And without spending time looking at this diagram, this is from a recent review paper pointing out that post-traumatic osteoarthritis has an important component of synovitis in its original pathogenetic pathway. So back to my old histology picture from my PhD. Of course, we know a lot more about biochemistry and molecular biology than we did then. And this is a diagram that just making the point, synovitis, inflammation in the synovial membrane, leads to a number of pathways that are potentially degradative to the cartilage. And in that same article, I showed you a slide of, in human PTOA, it's interesting that synovitis and inflammation is the first big part of this gradual road from trauma to osteoarthritic change in the articular cartilage. So I should digress quickly into early diagnosis is key, because I'm going to spend the rest of the time talking about therapies, but we need objective parameters for personalized medicine. One of the big difficulties with human OA is getting new drugs licensed. We pretty much rely on non-steroidal anti-inflammatory drugs, There are some others coming along, and I'll talk about stem cells at the end of the talk. But this is a review paper that came out of a Havemeyer meeting where we've had 3 of these. Dorothy Havemeyer Foundation sponsors think tanks for equine clinical problems. But the beauty of these biomarker Havemeyer meetings have been that we've had the gurus of biomarkers in osteoarthritis in people there. Stefan Lomander from Sweden, Virginia Kraus from the University of North Carolina, Linda Sandell from Washington U, Missouri, Bruce Caterson from Cardiff, originally Australian, and then us working with us veterinarians to try and make things better. And the bottom line is the only future, in my opinion, for optimized therapies being licensed for osteoarthritis in people, which is getting a bigger and bigger problem, is being able to have a biomarker where you can use the patient as their own control, and you can look at the biomarkers before and after treatment and make objective decisions as to the efficacy of that treatment. So this is another diagram just to show the point of stages of OA in the high motion joint. Start off with this is a normal joint, you get inflammation, the articular cartilage is still good, and then as you gradually progress through the stages, if you can't treat it effectively and stop the process, you end up with complete loss of articular cartilage or erosion down to the subchondral bone. So synovitis is the main target of therapy for us, and the principles with treatment is return the joint to normal as quickly as possible, prevent the occurrence or reduce the severity of OA. In other words, reduce the pain and minimize progression of joint deterioration. Now, we've borrowed this term from rheumatologists, but as equine vets, we're kind of doing better with understanding the disease-modifying parts. So we divide it up into symptom-modifying OA drugs. So they're the ones that, in the case of the horse, they're going to take away lameness and pain. You may see a reduction in synovial filling. And in humans, of course, reduction of pain is what's important. And that's a symptom. Now, disease-modifying drugs is that we've been able to, through research, know that we've got articular cartilage damage there, and we're helping it. So in other words, can we modify the disease process? Now, obviously, surgery is important as well. I've been to a couple of seminars. There's a lot of seminars going on in biologic therapies and quote-unquote stem cell therapies and new therapies where it's almost like you have 2 factions. You have the non-surgeons who are getting up there and saying, we're here to eliminate orthopedic surgery. That's never going to be the case. It's a combination. We certainly treat many horses medically, but we need surgery as well for those indications that I had on the slide. Now, these are options for the treatment of traumatic arthritis and osteoarthritis that we've looked at with research, and we've looked at with a model, and I'll come back to select some of these treatments because I obviously haven't got time to talk about them all. But the majority of our control-based testing of different treatments has been done using this equine osteochondral fragment model. We're talking about osteoarthritis at the moment. I will include quickly a little bit on articular cartilage repair because that's sort of a subcomponent of this area. Our treatment is we developed this model based on an equine clinical problem. There's a specific area that if we get fragmentation, it's on the distal aspect of the radial carpal bone. Osteoarthritis, if you don't treat it effectively and quickly with arthroscopic surgery, will ensue concomitantly quickly. We can characterize the disease-modifying effects because we look at the cartilage at the end of the study. And so it is relevant to human translation, and I want to give you a few examples of more topical cases where this has helped us understand better and provide evidence. Everybody talks about evidence-based medicine. There's 2 definitions of that, of what you try and accomplish in the field, either as a clinician or as a researcher. And then there's the ones who review your papers that are often statisticians who have never looked at a swollen joint and they declare that you haven't got enough numbers, or you haven't got the right proof, or your controls aren't good. It's a difficult area, but that's why we've relied on this model to really look at it. Now, physical therapies and rehabilitation has become very important to us for a couple of reasons. First of all, there's a new specialty called the American College of Veterinary Sports Medicine and Rehabilitation. But it's a rapidly growing field, and the old cliche, use it or lose it, is definitely the case. Now, why do we want joints to be functional? Obviously, these athletes, or I'm not quite sure whether you call this an athlete or a double-jointed person, but we need mobility, and people need to be able to play sports. Swimming and underwater treadmills are pretty popular tools. I'm just going to focus on the one that we've looked at scientifically, and that's underwater treadmilling. This is Melissa King. She was in practice for 10 years, then came back and did her PhD with us. She now leads the Sports Medicine and Rehab Center that formed out of the Orthopedic Research Center. And it was interesting because we looked at what does underwater treadmilling do in our equine OA model. It not only decreased the amount of osteoarthritis, secondary osteoarthritis in the model, but it also improved the horse's postural stability. We have these postural sway techniques that we can measure that Dr. Hausler brought with him, and significantly improved that. In other words, we think proprioception is very important. We know that we lose proprioception with osteoarthritis, whether we're a person or a horse, and certainly you want as much proprioception as you can get when you go back into athletic exercise, or if you're just convalescing from a hip replacement or a knee replacement in the case of people. Intra-articular corticosteroids have been around for a long time. They were first described in people in 1950 and horses in 1955. However, they're an interesting example of dogma being refuted with good investigation. They're still a very common treatment for us in the horse. They're also used frequently in people. The untoward effects have often been generalized and overstated, and they're often factitious. Now, what happened to me, fictitious I should say, sorry. This is a good example of clinical observation. As you know, I got invited down to do surgery. In California, I was scrubbed in with Dr. Bart Baker, who was the owner and head of the clinic. I was operating a horse. It had chronic fragments that obviously been there for some time, but the articular cartilage looked good, looked normal. And so I said, Bart, you know, this horse, you mustn't have injected this. He said, I've injected this horse 20 times. So then, and I don't think he was telling the truth, but he was treating with beta-vet soluspan, which is a beta-methazone ester. So we came back and started work on the model. This was a study that Jeff Folan was a resident for. And the two dogmas were you shouldn't use corticosteroids intra-articularly, but if you did, you better rest the horse. So we proved both of these things wrong because we had 4 groups, and the exercised horses that got beta-vet soluspan, when you had a chip in the knee, they had the healthiest cartilage at the end of the study. However, we looked at depomedrol or methylprednisolone acetate, and as some of you know here, we showed that these were definitely deleterious to the damage greatly exceeded the benefit of using this particular drug. We've published this, and so we use a Mankin score as a mark of degeneration of the articular cartilage. So here we had a treatment that was causing harm. On the other hand, one of the other corticosteroids, triamcinolone, Vetalog, tested with the same design, not only significantly decreased lameness, as you see on the left-hand picture, but also decreased the amount of secondary damage. By the way, this was really interesting because it's been a series of learning things. The other thing that people thought was you put corticosteroid into a joint, it stays there. Because there'd been pharmacokinetic studies done showing that there was no evidence of it going into another joint. People had looked at the level in the fluid in the opposite joint. But this was a group where we've put the corticosteroid, the treatment, in the joint opposite the one with the osteoarthritis. we still got a significant decrease in the osteoarthritic joint, a significant decrease in inflammation and lameness. And so we know now that they're very powerful drugs. This is a more recent paper actually done out of Liverpool. Pete Clegg is a veterinarian but has been involved in a lot of human research back there, showing that when they looked at activated protein C that's activated by corticosteroids, the only drug that wouldn't, with the exception of MPA, all corticosteroids cause significant decrease in interleukin-1 plus APC destruction of the collagen in the articular cartilage. There's been a number of studies in people, and the caveat here is they've shown no differences between triamcinolone and methylprednisolone acetate or between corticosteroids and hyaluronic acid, but they're not looking at the effects on cartilage. They're just looking at the symptoms, where because of our work with the model, we've been able to look at the articular cartilage and get a better idea of the effectiveness. And as I pointed out, in this next slide, I think, can we extrapolate these results to the human treatment of OA? Probably, I think we can, because articular cartilage is articular cartilage, and there's no question that it has degenerative effects when that particular drug is used, epimedrol is used, but the others are fine. I'm not going to talk about these treatments that I've outlined in red. They're all important. They've all been elevated, everything except the last one. We've assessed with the model exactly what's beneficial. We know that intra-articular polysulfated glycosaminoglycans is beneficial. We know we haven't been able to demonstrate any benefit from intramuscular, at least at the dose rate that's commonly used. We've seen remarkable stuff with intravenous and oral HA, but we'll just move quickly on that. But we have shown oral HA to have a benefit, and we've shown some other oral joint supplements that are very commonly used by people as well as horse owners to be beneficial, but certainly a lot of them to be not beneficial. So the rest of the topic here that I want to talk about are the new biologic therapies, anti-cytokine therapies, platelet-rich plasma, mesenchymal stem cells, etc. So we divide them into two components. We have gene therapy and ACS, and I'll go through some of the important ones, which are our protein-based treatments. With gene therapy, we're producing more protein, but it's a protein pathway, and then the cellular ones. So let's back up as far as what are we trying to do? It's a mixture of inhibiting catabolism and promoting anabolism. And there's a bit of a seesaw here. So here's a slide animation that, it's not coming up, sorry.
Joints are well designed to handle the
Let someone else talk here.
Exercise. However, due to cyclic trauma, inflammation of the synovial membrane and synovitis and capsulitis of the fibrous joint capsule are common events in athletic horses. Inflamed synovial membrane secretes a number of mediators that are deleterious to the articular cartilage, as well as causing pain. In addition, the inflammation attracts leukocytes that travel via the blood vessels to the synovial membrane and enter the joint cavity.
This was an animated program we made to make pathobiology easier to understand.
Chondrocytes can release metalloproteinases, aggrecanase, and PGE2 in response to stimulation with interleukin-1. Interleukin-1 is considered to be at the top of the degradative cascade in equine osteoarthritis. The interleukin-1 molecule acts on the chondrocyte through IL-1 receptors on the cell surface. Upon attachment to the IL-1 receptor, a signaling protein cascade is initiated that travels through the cytoplasm into the nucleus and changes DNA expression. Genes are upregulated and mRNA for certain deleterious factors, particularly MMPs, aggrecanase, and PGE2, Synthesis of these proteins occurs in the endoplasmic reticulum. The mediators produced include PGE2, MMP3, which, along with aggrecanase, causes degradation of proteoglycan molecules, MMPs 1 and 13 that cause degradation of the type 2 collagen molecules, and free radicals, which cause degradation of the hyaluranin in the joint fluid. As illustrated here, MMPs 1 and 13 break down collagen, while MMP3 and aggrecanase break down proteoglycan, and free radicals break down HA. Focusing down on the proteoglycan components of the aggrecan molecule, aggrecanase causes cleavage at one location on the protein backbone, and MMP3 causes cleavage at another location. This close-up view of a collagen fibril shows how MMP1 and 13 cause cleavage of the triple helix 3/4 of the way along the molecule. Breakdown of the cartilage matrix causes the microscopic changes of fibrillation and loss of articular cartilage, leading to full-thickness erosion.
So this knowledge has led to targeted biologic therapies, and there's more and more coming along, and I'll just give you some examples of where we're going. But the bottom line is, and I'll show you proof of that in a minute, is that this is the Frisbee modification of the McIlwraith diagram, making it really simple. IL-1 is bad, IL-1RA is good. IL-1 receptor antagonist inhibits it. And this study was shown, we showed proof of this with a gene therapy study whereby Rick Howard, one of our earlier residents and grad students, had cloned the gene for equine IL-1 in a colleague's office in Dr. Jenny Nyborg's lab. And then we collaborated with Dr. Chris Evans, who was at Pittsburgh at the time, is now at the Mayo Clinic, using his adenoviral vector. And the principle of gene therapy and the way we were doing it is you take out the replicative gene of this viral vector, you put the therapeutic gene, in this case interleukin-1 receptor antagonist, then you inject it into the joint, it goes into the synovial membrane, we now know it goes into the cartilage as well, and starts an internal manufacturing plant of the protein you want, in this case equine interleukin-1 receptor antagonist. When we tested it in our chip fragment model, we have 8 horses in each group, give us statistical power, we showed complete inhibition of all the clinical signs of OA that we have in this model, as well as the pathologic signs. This is just an example of a safran and O fast green, safran and O staining the glycosaminoglycan. This is the control. This is a single injection of equine adeno IL-1RA. So we stopped it all. Now, we had some trouble with that vector on repeat injection, and so there's been a lot of work done since then, principally with Laurie Goodrich in our lab. She's a boarded surgeon, obviously with a PhD, working with Jude Zamolsky at the University of North Carolina. This is actually an arthroscopic view. See the little green dots? That's because we've put green fluorescent protein on the vector to see how long we get transfection, in other words, protein production. And this is 4 months after a single injection, so we're getting better and better. We actually got good transfection all the way out to 6 months. Something that's interesting is we know synovial cells turn over quickly. They're not going to be the original ones that get transfected, aren't going to be there at 6 months, but the chondrocytes are, and that's why we're seeing this uptake of the green fluorescent protein there. So we're making progress. There's been a number of studies since then. Now, what have we got available at the moment? This is autologous conditioned serum. It was initially a product called Orthokine, used in humans. There's a number of prominent athletes gone over and had it done. Basically, we incubate blood with these beads for 24 hours. It causes an upregulation of various factors, including equine interleukin-1 receptor antagonist. We then get enough after we centrifuge that incubated material for 3 to 5 intra-articular injections, depending on the joint. And we've tested it in our model and shown that we had no adverse effects. We had horses treated with ACS, significantly reduced lameness in the OA limbs, and even 5 weeks after the last treatment. So they have long-term knock-on effects, these types of biologic therapies. Now, there's since been a second product called IRAP2 that is a new device, and in comparisons of IRAP2 to IRAP1, there's even a higher level of interleukin-1 receptor antagonist. And if we look at the ratio of interleukin-1 receptor antagonist to IL-1 beta, that's the bad guy, you can see that it's even more marked, the difference between the two products. So we're gradually improving. And most recently, we've had a graduate student, a PhD student, Livia Corbin, working with Dave Frisbee, that we've shown that freeze-dried IRAP, so we can take it allogenetically, we can just take it from any horse, we can incubate it, produce it, freeze-dry it, and it's still as effective as the autologous product. And then, of course, we get a doubling of various growth factors such as IGF-1 and Tgf-Beta. This is just the dose, which I'll pass over in the interests of time. Got a bit held up with the break. Platelet-rich plasma, I'm only going to show you 2 slides, not because it's not important or potentially important. It's a popular product in humans because it falls under the FDA definition of minimal manipulation, and there's a lot of it being used. However, we haven't done much with the horse in joints. We have used it quite a lot in suspensory ligaments and tendon injury, but at the moment we know, this is a paper from Lisa Fortier, who's a DVM PhD at Cornell, well known to quite a few of the people here, and it's a really nice paper pointing out all the different pathways that are involved with PRP. But at the moment, we don't have any data in joints in the horse. So the main one we're using is the autologous condition serum, or IRAP. There's other products coming along. The second area, of course, is mesenchymal stem cells. And we could talk on this all day, but just to say that the types of MSCs, how and when the subject is the subject of debate. There's various papers. This is a paper that reviewed it quite nicely. This is a chapter from our joint book. So I'm just going to talk about mesenchymal stem cells based on bone marrow culturing. We've had some good discussion today and last night with Thomas Koch, who's got a great stem cell program here. The main things that I want to talk about with stem cells quickly is what we've had success with, how we think they're working. This slide says it all, really. I think that everything we've done in the horse confirms what Arnie Kaplan at Case Western talked about. We used to think that we'd put stem cells in, or it was proposed you put stem cells into a problem, into a lesion, whether it's an inflamed joint or a tendon, and they'd multiply and then turn into the cells that you want. In other words, in a tendon, tenocytes, in a joint, maybe chondrocytes, and make cartilage. Whereas it's now known that the main activity is the trophic factors, the bioactive factors that the MSCs produce influencing the intrinsic cells. So they're not only immunosuppressive and decrease inflammation, but they can also promote growth. So the pivotal study that demonstrated that, to us at least at CSU, was the study by Frank Barry, who looked in a goat model, or Frank Barry's lab, actually. Mary Murphy was the lead investigator on this, and she's Frank's wife. What they did is they took the meniscus out of goats and they cut their cruciate ligament and put 10 million autologous bone marrow derived cells in 6 weeks after with HA, compared to HA alone as the control, as the other group. And they showed not only regrowth, considerable regrowth of meniscal tissue, regenerating meniscus, but also decreased the degeneration of cartilage. Now, I'm going to focus on one clinical area with us that we've shown with clinical studies. These were studies done, all these horses were arthroscoped, so we defined the disease. We get three categories of disease in equine joints. We get osteoarthritis, we get cartilage defects, and we have damaged soft tissue such as the meniscus and the meniscotibial ligaments. And in femorotibial joints, which is a nice equivalent to the human knee, there's components of all three. This is just degeneration in the articular cartilage. This is a meniscal tear. And so this is 39 cases where we had 24 plus or minus 2.6 months follow-up. They were all courses that had failed routine treatments. They had a mixture of meniscal cartilage or ligamentous injury, and a high percentage returned to some level of work, and 42.4% returned to or exceeded their prior level of work. Dividing it up into two things that are important to us as clinicians was articular cartilage damage, some degree of damage in all 33 cases. Most of them were superficial. They have fibrillation, this furry cartilage here, but 7 out of 33 had eburnation. They had erosion down to the bone, and then after you get down to the bone, you start getting polishing of that bone. 6 out of 7 of these returned to work, and 5 out of 7 to the same or level, which was pretty astonishing results. Now, I realize the numbers are a bit low, but they're pretty telling. These are injuries that we definitely wouldn't have expected for them to come back when we used arthroscopic surgery debridement alone. Similarly, with meniscal injuries, we had tears that we couldn't even completely debride that came back successfully. So we've done I'll pass over the experimental osteoarthritis. That just gives us some more ideas on treatment. And then say that intra-articular injection of MSCs has also been shown to enhance focal defect repair. And the interesting thing with the MSCs is intra-articular injection in general has been very positive with cartilage repair. And I indicated that those clinical results were even when we had full thickness cartilage erosions on the medial condyle of the femur, we still got them back successfully. In this case, we did an experimental study, and we showed that we had increased firmness of our repair tissue and increased aggrecan content. However, on the other hand, we haven't had the same results when we put the stem cells into a matrix or into a hydrogel in the defects. I just want to digress quickly. We've done a lot of work with articular cartilage repair because of various techniques, but we started a desire to validate microfracture in humans. This is a technique led to the development of the first model of articular cartilage repair in horses. And this was a relationship with Dr. Richard Stedman, very prominent knee surgeon who developed microfracture. It's a simple technique. We make pick holes we get down to the bone, and we make pick holes to get some blood supply into the defect. We have a clot form, and then we have shown that with our research in the horse, Dr. Stedman came to us wanting to validate microfracture in the horse if we could. We showed that you got increased repair tissue, and this was a really important paper, at least to human orthopedic surgeons as well as veterinary orthopedic surgeons. We showed that if you didn't remove the calcified cartilage, this layer down at the bottom overlying the bone, you didn't get good integration of your repair tissue, and your repair tissue was poor quality. Whereas if you did remove it, you restored calcified cartilage and you had very good attachment of your cartilage to the bone. So, however, I gave you this however before and then interjected those two slides. This was a study that was funded by the National Institute of Health that we did with Connie Chu, who's an MD orthopedic surgeon at Stanford. Connie and Laurie Goodrich here. And what we did is that we created defects and we put stem cells in with fibrin. And the surprising result published in the Journal of Bone and Joint Surgery was that the group that had no stem cells did better. And not only that, but 4 out of 12 of them grew actual bone in the defect. You certainly don't want bone in your articular defect. So there's a lot of reasons for that, but the short version is that it looks like if you trap the stem cells in fibrin, which we did in this case, well, it was a fibrin mixed with PRP, they can't do their thing. So at the moment, simple is better as far as intra-articular cells go. So this is a summary of the current use of stem cells in the horse. The clinical data is very positive. We certainly haven't been able to translate it all to humans yet because of restrictions with FDA. That's a regulatory problem. The only really technique that could be called stem cells that's being used, at least in the US, there's a bit more flexibility in Canada, is bone marrow aspirate, which consists of some stem cells from the bone marrow, but they haven't been cultured, so they're in low numbers. This is probably the other message regarding stem cells. It's a very abused term. This is an advertisement that comes wrapped around the Denver Post when I get it, advertising stem cell injections. They're not stem cell injections. It's sort of, and it's still happening. You know, my paper on Saturday had this. And so you've got to beware. There's a lot of stuff out there that's not true. So this is the next step in the story that Gordon's nicely introduced. Funding due to these, we initially, Mindy Story was a veterinary surgeon, boarded surgeon working in practice in South Denver. She did work on Leslie Malone's dressage horses. This is John Malone. And Mindy wanted to join our program in sports medicine. That led to a meeting with Leslie and John, and they funded an endowed chair to create a position in equine sports medicine. At the same time, we knew John expressed an interest in stem cells. We'd never had a donor ask for data. And so we gave him some slides on our stem cell work, as well as the equine sports medicine program and the Orthopedic Research Center. And John turned around and said, I want to come and see your data on stem cells. So that led to a second meeting where he came up and we gave him an hour presentation on what we'd done in stem cells. Obviously, I've gone over it very quickly in this talk for time, but and then later on we had a third meeting in which we gave him this idea of the Translational Medicine Institute doing what we're doing for horses, but doing more for humans. We had a not nearly as nice a picture of the building at that stage. He said he'd be the lead donor, and the fourth meeting resolved on him being the lead donor and us having to get matching donation, where Abigail Kawananakoa came through with another 20 million on top of the initial, and the university kicked in 10, and so that has led to this building. And the mission of this is really just an amplification of what we've talked about with biologic therapies, to innovate medical discovery paradigms and solutions leveraging nature's healing capacity. John's a very successful businessman. He owns Liberty Media. He was one of the cable TV originators. And but the idea is that we're going to create these, continue to create novel biologic therapies, which we have tools now that we can do this quite efficiently in recognizing targets. So that's sort of the last part of the story. Obviously, you don't do this work without a lot of help and a lot of people that are really critical to us, not just at CSU, at the ORC, but our collaborators as well. Thank you.
Thank you very much for an excellent talk. I think we're running a bit over time, maybe time for one or two questions.
I get away with none.
So hearing none, there'll be an opportunity afterwards in a reception across the hallway to ask questions directly. I'd like to finish the proceedings today by asking Brett Flynn to present the Schofield Medal on behalf of the Central Veterans Association.
Wanted to thank you, Dr. Callery. No worries. For coming all the way out here from Colorado. Thank you from all of us here from the OVC and the Central Veterinary Students Association. And we're proud to present you with this medal.
Well, thank you.
Thank you. Round of
Thanks
applause.
a lot.
So that ends the proceedings for today, and you're welcome to join us for refreshments across in the cafeteria across the hall. Thanks for coming.